Hello, and welcome to MedNews Week, the rising leader in global medical education. You're watching Medical Spotlight, where we highlight the inspiring stories and pioneering research innovation of medicine's rising stars and global leaders.
Hello, and welcome to Medical Spotlight. My name is Madhuri Balasubramanian.
And I am Jenna Gazelle.
And today we have with us Dr. Marc Braunstein. Dr. Braunstein is an associate professor of internal medicine, co-director of the Hematology Organ System, and the fellowship program director of the Hematology Oncology Division at the NYU Grossman, Long Island School of Medicine. He completed his undergraduate degree in biology at the CUNY Brooklyn College and his MD and PhD at the SUNY Downstate. He completed his internal medicine training at the Hofstra Northwest School of Medicine and his hematology oncology fellowship training at the NYU School of Medicine. Dr. Braunstein is also part of the Phase 1 committee that conceived the first-year curriculum for the NYU Grossman Long Island School of Medicine. He serves on the national educational committees of professional societies, including the American Society of the Hematology and American Society of Transplant and Cellular Therapy. He is also the vice chair of the Committee for Early Career Physicians as a part of the New York chapter of the American College of Physicians.
Dr. Braunstein's research interests are in three general areas: hematologic malignancies, specifically lymphomas and plasma cell disorders, quality improvement, and medical education. His research activities include serving as site principal investigator of industry-sponsored clinical trials, retrospective studies that include oncology database mining, as well as quality improvements research and publication related to case studies and literature interview. At Perlmutter Cancer Center, he treats people with various types of malignant and benign hematologic conditions, with emphasis on hematologic cancers. He has specifically focused on plasma cell disorders, particularly myeloma. He also sees patients who also have iron deficiency, bleeding, and clotting disorders, and cancers involving the bone marrow and lymph nodes, such as lymphomas. He has received funding from the Association of Community Cancer Centers, Janstein, and U-Biome to advance his work. He has published extensively in the area and has been invited to speak both internationally and nationally on his research. He is also a very passionate mentor, serving as a leader and educator, and we are delighted to have him here today. Now, Dr. Braunstein, behind every person in a white coat is a story and mission for why they pursued this journey and career. Tell us about yours.
Well, thank you, Jenna and Midori, for that very excellent introduction, and makes me feel older than I think I am, but I'm very humbled by the journey. And so, I really find it fascinating what everybody's journey is to get to the path of medicine or scientific research. And in one of my roles that you mentioned as program director for our fellowship, I really enjoy reading all the applications that we get from applicants to see how far they've come and what their individual story is, because it's really fascinating how what leads people towards this path. In terms of my personal story, I think that going through high school, I wasn't really sure exactly what I wanted to do. No one in my family was really in the healthcare field. My father was a high school teacher and also a lawyer, and I thought, that's exactly what I'm going to do. And then, I joined the law club, and I wasn't as interested in it, and I felt I was drawn more towards science. Also, at the same time, my older brother was kind of a pre-med student and going through the science courses, and was sort of like a mentor to me and got me interested in science and medicine and healthcare. I did some volunteering, like most people do in a hospital, and just kind of sapped everything up. I was just interested in every part of what people were doing, from the nurses to the physicians to the respiratory therapist. I was just really interested, and I found myself, really engaged, and the time just passed quickly. And I thought, this is really what I'm interested in, but I want to be able to merge the science and the medicine. At the same time, I had a family member who was going through colon cancer treatment. And, I really saw exactly what patients and their clinicians manage with every day in terms of the process, the compassion, and talking about treatment options. And so that really led me towards oncology. When I went to medical school, I was in a dual degree MD PhD program. And in my second year of medical school, I found one of our lecturers who was a hematologist oncologist who was doing research actually in the field of multiple myeloma. And I thought she would be an excellent mentor for me. Her name was Dr. Olcay Bottoman. And she really motivated me to pursue oncology even further. She was so passionate about research, about bench to bedside science. And I learned so much about how to write a paper, how to formulate a hypothesis, how to do bench research. And I got the opportunity to attend the American Society of Hematology meetings as a medical student and present at those meetings. And that was just absolutely thrilling. And so the culmination of those experiences, predating and throughout medical school, really solidified my interest in pursuing oncology. And just one last part of that is I didn't think I would be this involved in medical education, but I'm so glad that just serendipitously, I have become involved in medical education, largely as a result of the formulation of our medical school, the NYU Grossman Long Island School of Medicine, which I think it's probably once in a lifetime you get a chance, if at all, to be part of a brand new nascent medical school and be part of that process. And so I love what I do. I would choose this field again in a heartbeat. And I'm so glad that I have the opportunity to work with patients, other clinicians, and trainees every day and just make a difference.
Yeah, thank you, Doctor. You talked about a little bit about a couple mentors you've had throughout your journey, and I just want to ask a question of how does your strong passion for mentorship manifest in your present role? Do you think this could describe the ways in which you currently apply mentorship to guide and support the development of your junior colleagues?
Sure, that's such a good question, Jenna, because mentorship is crucial in any field, but especially in medicine. I mean, historically, we have a field where information was handed down from generation to generation, and we stand on the shoulders of many giants in the field that have propelled us further in terms of the medicine and the science. In fact, I just myself and my program director, Dr. Michael Schusterman, who's a fellow oncologist in my institution, we just presented a whole talk on mentorship at the American Society of Clinical Oncology's program leadership retreat a couple of months ago. And that talk was really born out of our experiences both as mentees and now as mentors. Mentorship is important at every level, whether you're pre-med in medical school or beyond. It's really important to find someone who really cares about your career and is willing to have a bi-directional conversation about how they can help you and how you can have a symbiotic relationship. There's different types of mentors. There's advisors, coaches, and then true mentors who are going to try to promote you and to get you to where you want to go and help you in your career. And because medicine is so complex, and especially in academic medicine, when there are a lot of different stakeholders and it's expensive to do science and you have to apply for grants and clinical trials take a lot of your time and sometimes you need to carve out time. It's so crucial to have good mentors, and maybe even more than one, who can give you opportunities to talk at conferences or be involved in a research project or educate you on things you didn't learn in medical school, like self-promotion, using social media, writing a grant application, and various other things that are so important. So if you're someone who's just thinking about a healthcare career or already involved in it, I would say it's so important, whether you think you need one or not, it's so important to have a mentor or a coach or an advisor there's someone who can help guide you, because no matter what phase you are in your career, even the most senior person, the division chair, the hospital leadership, they need mentors too. And it's always helpful to ask questions to those people in situations you didn't think you would encounter. So mentorship is really critical.
Yeah, of course, it's so important to have someone to always guide you the right way, especially when we're kind of lost in a place we don't know. Um, Humans have always dealt with setbacks, but they can make you or break you. Would you mind reflecting on challenging time in your life and how one should approach these speed bumps?
Sure, that's, you're really pulling these wonderful questions from the question bank here. And so, if I would say one important piece of advice that I've learned throughout my setbacks is that um, although it takes a lot of work to be successful, in some regard, success is easier than failure, because you learn a lot from failures, and you have to keep the faith during those failures. You have to remember that it's darkest before dawn, and that not everything is going to be easy, and that what separates people who are very successful from those who are not is really how they overcome those hurdles, right? Because the threshold to get from where you are to even more successful is often just getting through that storm, those difficult periods when you think everything's falling apart and you've encountered some setback or some failure. And everybody has their own story that they don't always say up front, whether it's they had to reapply to medical school or residency or fellowship, or failed a course, or didn't get that grant, or had some personal health issue, or other relationship issue. There's so many examples of our day-to-day lives where things don't go according to plan, and we feel really rejected and feel like it's not going to work out. When I was transitioning from graduate school back to the clinical years of medical school and MD PhD program, it was extremely challenging. I didn't know most of the class, and I didn't remember a lot of what I learned the first years of medical school. And the world of being a PhD student is so different from how things operate in the clinical world. It was very challenging to make that transition back. And I felt very much behind the curve. And so I had to tell myself, I have to seek out help. I maybe need some tutoring to remember how to, study the material for the clinical coursework. And so, that's just one example. I mean, during my graduate school years, it was very challenging. A lot of times you're somewhat isolated, just you and the bench, and you really have to be motivated to say that these experiments might not work out the way I planned, but I'm going to keep going at it. I'm going to try to pursue my hypothesis and try to prove it. And then in the clinical world, every day, as an attending even now, we face many challenges with our patients. Every person has their own individual lived experiences, their own needs, their own degrees of health literacy. And, we have to help them in their journey to overcome their hurdles. And, as an oncologist, you sort of feel those challenges personally, but you have to remember that you're there to help them get over them, and you have to maintain that, professional confidence. And it still feels like you're with them in that journey, trying to get over their challenges. So at the end of the day, it's really important to continue to be faithful and hopeful that you're going to get through this challenge, and you're going to continue to achieve your goals.
Yeah, always having that hope is something that everyone should strive for. And thank you for that wonderful story about that. So we have many trainees in the audience. Given all your career success, what type of piece of advice would you like to leave with them?
That's a great question. First of all, I never really consider myself successful. I mean, when you attend conferences, like I just got back from the American Society of Hematology conference, and you see these sort of giants in the field who have accomplished so much, who made practice changing publications. I always look at them in awe and say, I can never see myself at that level. And so there's always another level of success. I think we each have to define what success means to us, and not feel like we are not good enough, right? There's a lot of imposter syndrome as we go through the different levels of medical training, there's always somebody who knows more than you or accomplished more than you or has published more than you, and it's very easy to have that imposter syndrome. And so my advice is that, if you are focused, if you have a goal in mind, if you're able to overcome setbacks, don't listen to the naysayers who tell you can't do it. There's always a way to get to where you want to go. Seek out that mentorship, and remain focused on your goals. And if you haven't found the right person or set of people who are invested in you, keep looking and you'll find it. There's many ways nowadays to make connections, whether it's social media, bulletin boards, online, just making phone calls to different institutions. You can find the contact information for many scientists and physicians online. There's many ways to seek out that mentorship, but you really have to stay focused and keep in mind that throughout the journey, there are times when you're going to feel alone or isolated or feel like you're carrying the weight of the world on your shoulders by yourself. And you have to remember that there are others like you, that if you keep going, you'll eventually get to your goals.
Yeah. Okay. That was amazing of the advice everyone has now. You are an advocate for medical and patient education and personalized care, especially on social media. What inspired you to raise awareness on this particular platform?
So, I mean, if you think about it, at the core of what we do, even if we're not an academic institution, we as clinicians are educators. And that's educating our patients, educating the people we work with, or our trainees, or our staff. And so medical education has transformed in the past few decades, where it's no longer about one person delivering all their information, but figuring out how you can break through to the learner in order to engage their individual learning style. And fortunately, we're at a time where there's so many different platforms available now to offer to different learners that have different styles of learning. So, day to day, it's really a privilege to see the light in people's eyes when you do break through, or you make them smile or laugh or get a concept, especially when it comes to patients. I can't tell you how many times, and I really say this with gratitude, how many times patients have told me, you're the first one to really explain this condition to me, or to really make it make sense. I can tell you really care because of the way you're explaining it. And so it's a lot of fun for me to be able to break something down, to take all the kind of complicated or complex data that accumulates for a particular patient that they don't really understand, even if they have access to their chart, and to be able to weave a story about what's going on with them and how we're going to get them into better health. And the same goes for the learners. I love using techniques they probably never had before. Like we all take out our smartphones on rounds, and we have them look something up and talk about it in real time. Or I've had my fellows draw out a concept, like draw out what a plasma cell looks like, or draw out the clot, an element of the clotting cascade, and then they'll show, even when we were doing this virtually, they'll show it on the Zoom, and they'll be able to just for fun see what their different individual drawings look like. So little things like that, just to break up the monotony, because there are many ways to make a boring lecture, but it takes a lot of effort to make an engaging and intriguing, didactic course. And so, time is, as you get older, your most valuable resource is time. And as you get more advanced in your career, you have less and less time because you take on more responsibilities inevitably, whether it's personal or professional. So time is always going to be a limiting factor, but with the amount of resources there are now for educating both patients and trainees and house staff, it doesn't really take that much effort to put into making a lecture from ordinary to extraordinary.
Okay, thank you for that wonderful, very explained answer. Thank you so much.
Thank you. My pleasure.
Dr. Braunstein, first of all, really thank you for your amazing and enlightening viewpoint. And I hope when I start my residency and fellowship later on, I have an interesting mentor as yourself. Someone who,
Thank
a
you.
professor who's as interesting as you, the way the
I'm sure you
techniques and
will.
everything as well. So
Thank you.
thank you so much for that.
My pleasure.
And you had mentioned that some of your amazing interest and passion projects and publications. What is something that you're currently or presently working on?
So after I became an attending, I took more of a clinical position, but I do have a background in sort of translational research. So I consider myself fortunate now to be at the NYU Grossman Cancer Center, where we have the opportunity to bridge the clinical and basic science. And so two of my mentors in the field of multiple myeloma, who are very well established, Dr. Faith Davies and Dr. Gareth Morgan, are mentoring me in a project looking at the genomics of multiple myeloma. When I was a graduate student, I was looking at the multiple myeloma microenvironment, which are the sort of the neighborhood that surrounds the tumor and the microenvironment of the bone marrow. But currently, I had the benefit of collaborating with Dr. Morgan's laboratory members on a project looking at structural variation in the genome of plasma cells at various points in the disease. These are cells that are responsible for multiple myeloma, which is a cancer of plasma cells that divide in the bone marrow. And the disease progressively becomes resistant to treatment, like many cancers, but especially in multiple myeloma, where the disease evolves to resist treatment and become progressively genetically unstable. And so we're looking at different structural variations in the genome of these plasma cells at various stages, and also looking at differences in different demographic groups to see if there are specific subgroups that have particular patterns that could be targeted for treatment as well.
That honestly sounds so interesting, is because this is something that I'm constantly studying about, and we're constantly hearing so much on the newer innovations recently, especially. So you'd mentioned
Sure.
a little bit about plasma cells as well. So could you provide a little bit of an explanation on what its role will be in the immune system itself, and what's its relationship with the development of multiple myeloma itself?
Oh, sure. To take a step back, plasma cells are cells that were originally born in the bone marrow as B cells, which are cells of the immune system that produce a protein called an antibody that fights infection. And so B cells eventually mature in order to figure out how to fight specific infections, and then they return to the bone marrow as kind of longer-lived plasma cells. So if you've gotten your COVID or your influenza vaccine, plasma cells will eventually lead to long-term memory by producing antibodies against those invaders through the vaccination, and be able to provide you immunity that we're not naturally born with. So sometimes, though, there are mistakes along that maturation, and that can lead these plasma cells to grow more in the bone marrow than they should. And that's a result of mutations that happen in those plasma cells. Now, some patients will develop a certain set of mutations that makes their myeloma kind of progress faster or resist treatment. We call those higher risk patients. And that's an area of unmet need in multiple myeloma treatment in order to be able to overcome those adverse prognostic features of higher risk mutations in those plasma cells. So the complication in multiple myeloma when patients present is that, one, they can be immunocompromised because this is a cancer of cells of the immune system, the plasma cells, and they often have a reduction in their normal markers of their normal immune system, like their normal antibody levels, for example, or their normal white blood cell count may be reduced. The other complication is that the plasma cells can invade into the bone and cause bone lesions, or the elevated levels of the antibodies they're producing can cause havoc elsewhere, like in the kidneys. They can clog up the tubules and cause a nephropathy. So it's a very dynamic disease, and we've come extremely far in figuring out how to target those plasma cells. But unfortunately, for the majority of patients, it remains incurable, though the 5-year survival is up to about 60% at this time, which has been a dramatic improvement in the past decade.
Oh, that's honestly really, I'm good to hear that, because not just knowing the background, but the rate of survival and how we can further overcome it as well is really interesting to learn. So thank you so much for that. And I had recently read your paper, actually, which a couple of months ago, that you published about autologous stem cell transplant. in as it's overcoming its barriers in multiple myeloma itself. Could you explain a little bit more about that?
Sure, that was a really fun project to work on in collaboration with the American Society for Transplant and Cellular Therapy, as well as the France Foundation. And myself and some colleagues and various stakeholders, including patient advocates in the field of multiple myeloma, got together to do a roundtable to address potential barriers to receiving an autologous stem cell transplant. So just to take a quick step back, in multiple myeloma, after patients get their initial therapy, there's data to say that consolidating the disease further by using high-dose chemotherapy, followed by rescuing their healthy bone marrow with a reinfusion of their previously collected autologous stem cells, can prolong the time until they progress. And there is some debate in the field about the role of autologous stem cell transplant in lieu of novel therapies being developed. However, what we were addressing was why the minority of patients actually go forward with autologous transplant, whether it's an access issue or whether it has to do with referral patterns, because most patients with multiple myeloma get treated outside of academic centers where stem cell transplant is generally available. So when they're getting treated in the community, they may not have either access to a referral center that does stem cell transplant, or they may not get referred at all. And so what we identified was there's various factors, including referral patterns, access, racial disparities in terms of referral, financial factors, health literacy factors. It really is important to offer patients treatments, even if they ultimately decline the treatment, which is perfectly reasonable. It's important to give them the options. And even in cases where I feel that an autologous stem cell transplant may not be required or indicated in that particular patient's disease, I still have that discussion to offer them the options and go through the literature, supporting it and why it may or may not be indicated in that setting. So this was a roundtable where we published the consensus kind of opinions of that group and reference the literature in terms of what are the potential barriers to receiving an autologous stem cell transplant in multiple myeloma.
No, honestly, that was really interesting to hear because I had read your abstract and everything on that, and I was so curious to learn more about it, which is, I think that's just like a personal factor for me as well. And something that I've recently been reading about and I wanted to know was more on the quality of life consideration. So, how does autologous stem cell transplant itself impact the overall quality of life for the multiple myeloma patients? And are there any strategies in discussion to kind of mitigate the potential challenges?
Great question. So, I think increasingly high impact studies of clinical trials or interventional trials are including metrics looking at quality of life. I think quality of life can be somewhat nebulous. We kind of have a sense of what it is, but on the practical standpoint, it might mean different things to different patients. And so there are some standardized surveys that you can actually give to patients, typically in the context of a formal clinical trial, but not exactly practical on a day-to-day basis when you're busy in clinic. But there are surveys that you can hand to patients to kind of capture in an objective way a quality of life score. So in a disease like multiple myeloma, which kind of behaves like a chronic disease, one of our goals is to preserve patients' quality of life because the treatments, even though they're becoming better tolerated in combination, they still can impact quality of life, less so than if the disease were left untreated, and the disease itself can very much impact quality of life. But still, we want to focus on preserving quality of life during treatment, during the maintenance phase of treatment. And so during a high-dose chemotherapy and autologous stem cell transplant process, the quality of life may be worse during that 4-week period when they're very much immunocompromised before the bone marrow kind of restores itself. And so even though we can do this procedure at our institution outpatient, where the patient doesn't even need to be admitted to the hospital, their quality of life may be worse than what it was during their initial induction chemotherapy, because this is a more intensive process. And so even though it's important to focus on quality of life in most cancers at any point in the treatment, is especially true during the period during and after a autologous stem cell transplant. In the period going through the process, we want to focus on things like nutrition, sleep, fatigue, among a myriad of other things related to the process itself, like diarrhea and nausea and things like that. But even after the transplant is over and the patient's bone marrow has engrafted and they've completed the process, we want to look at things like psychological distress, fatigue, even anxiety and how the patients view their own body and things like that, and just well-being in general. So we don't typically use surveys to assess that outside of a clinical trial, but it is important to ask those questions when we see patients. And many studies have been done where they've looked at quality of life, after a stem cell transplant, and have shown improved quality of life down the road after the transplant. But increasingly in many clinical trials, not just in multiple myeloma, but in other disease spaces, they are including quality of life as a kind of a metric of whether it's improved with the experimental agent compared to the control.
No, that was honestly really interesting to hear, because that's something that every work and every distinction and every process has such a huge difference and consideration about. And I was so curious to know about your opinions and your viewpoint on that as well. So thank you so much for that.
My pleasure.
Definitely. And, with all this research that's happening and all that you're working on as well, is there any particular direction that you plan to pursue in your further research based on not just your current studies, but also your past and future studies?
Yeah, that's a great question. I wear many different hats in my current role and have and am passionate about various areas that you mentioned, including education, quality improvement, and clinical research. And so I mentor many of our fellows in retrospective studies where we look at things like quality improvement projects and outcomes research and real world studies. I mentioned the project I'm working on with my collaborators in the myeloma field, looking at the genomics of myeloma. And then I'm also involved in clinical trial research, where most of our trials are industry sponsored, but I hope in the future that we can create our own investigator-initiated study in myeloma. And then I'm also doing, education research. For example, we're working on a project with one of our former fellows, who's actually now one of our faculty members, where we're using our simulation center to educate fellows on side effects from CAR T cell therapy, and we're just working on the publication now. But both the fellows and the faculty have really enjoyed that approach to educating fellows on the potential side effects of some of these immunotherapies. So those are some areas that I'm interested in and that I'm passionate about. And again, it's really been a result of the mentorship that I've had, that I've been able to mentor others in those various research fields.
No, that was amazing. And I hope to read more from you and your team and your amazing faculty as well.
Thank you.
Definitely. And,
Sure.
Doctor, we really appreciated the opportunity not just to learn about your research work and what you're currently working on, but also about the person and the man behind the whole process. So thank you so much for that. We have one kind of important final question for you. With everything said and done, what do you still hope to achieve in your career, and what is something that you want to be remembered for?
That's another great question. So I didn't mention my other very important job, which is being a husband and a father. And so I think it's very difficult for people like myself who are so excited about their work to find that balance. And so I certainly want to be remembered as somebody who was able to raise well-adjusted children and be a good spouse, and kind of was able to find the right balance. But the things that professionally, the things that I am interested in are I'd say at the end of my career, what I'll look back most favorably on is just mentoring other fellows and seeing what they've accomplished in their careers. I've always said, what's more important than my CV is what happens with their CVs and what they accomplish. Because I actually had the opportunity recently at the ASH conference to meet up with some of our former trainees, and it was just really gratifying to see how far along they've come in their careers. And they were thankful of my mentorship as well, which was very gratifying. So I think that's certainly a priority. From a research standpoint, I want to be part of the process in the path that we're on as a community in curing multiple myeloma. I think we're well on our way. There's so much good work to be done in terms of clinical trials, in terms of basic science. There's so much more to learn because essentially this is a disease that continues to return and we're not curing those patients. So there's really a lot more to learn. And I will have probably a very small role among the many brilliant people in the field of multiple myeloma that are promoting the science and pushing the bar further in terms of survival. But I'm just grateful to be part of that process, to publish and to do research in the field and to present at conferences and, work with teams of incredibly brilliant clinicians and scientists. And, I hope I'll be remembered as someone who was a collaborator.
No, definitely, Doctor. And I think you definitely will be remembered as one of the people who contributed to the whole understanding of the disease and everything more as well. So thank you.
Well, thank you so much. Thank you for excellent questions.
It was a pleasure learning about you and your important work, Dr. Braunstein. We just have one actual last question is, how can our audience connect with you?
I am happy to connect with your audience at any level of their career. I'm on, what do we call it, Twitter or X. You can find me at Doc Braunstein. You can connect with me through my email. It's mark.braunstein@nyulangone.org. I'm happy to communicate. Those are probably the two best channels. I'm happy to communicate and help as best I can. A lot of times we get messages from high school students or from residents or fellows looking to do rotations or research. We can't always offer them opportunities. It depends on the time frame and it depends on what they're looking for and what their goals are. But I always want to try to help them as best I can. So I'm happy to communicate in either one of those channels. My pleasure. Thank you both for the excellent questions, the opportunity to talk to your audience and just talk about the things I'm passionate about.